Let us now take the blessings from the goddess of learning and start today's function with a melodious rendition of the Saraswati Vandana. With the blessings of the Ma Saraswati and the Saraswati Vandana on us, may I now request Dr. R.K. Deman, Secretary General, INASL and Professor, Department of Hepatology, PGI Chandigarh, to kindly present us with the welcome address.
Dignitaries on the dais, friends and ladies and gentlemen. On behalf of the INASL, I am honored to welcome our chief guest today, Dr. Henk Bekkedem, WHO representative to India, who has graced the occasion despite his busy schedules. Prior to coming to the India, Dr. Bekkedem was WHO representative to Egypt, where he and his team focused on WHO's support to scale up of the treatment and prevention of the viral hepatitis. As you are well aware, hepatitis is increasingly being recognized as a major public health problem in India, with a burden comparable to the other major communicable diseases such as HIV, tuberculosis, and malaria. Dr. Bekkedem is a key force from WHO helping Government of India in formulating National Action Plan, that is NAP, for eliminating viral hepatitis by 2030. That is an ambitious target set by the World Health Assembly. We are grateful to Dr. Shiv Sareen, Director, Institute of the Liver and the Biliary Sciences, and Dr. Subrata Acharya, who have taken out time from their busy schedules to grace the occasion. Professor Sareen is a renowned hepatologist with several original scientific contributions, and he has, with the help of the Delhi government, created a Hepatobiliary Institute of the Excellence. Dr. Acharya, who works at All India Institute of the Medical Sciences, too is an active researcher in the field of the hepatology and an inspiring teacher. This scientific meeting will be having attendance of by approximately 150 faculty, all well-known stalwarts in the field of the hepatology, including several from the abroad, including from the USA, Patrick Kamath, Arun Sanyal, and Jasmine Bajaj. From Canada, Punita Tandon. From the UK, Anil Dhawan. From France, Paul Kales. From Italy, Paolo Angeli, Massimo Colombo. And from Spain, Xavier Fons. From Germany, Frank Take. And from Japan, Sheikh Mohammed Akbar. I thank all of them sparing time and being with us this time. I also welcome the Indian members of the faculty who have taken out precious time from their busy schedules and have come from different parts of the country. No conference is successful without delegates. I am happy to tell you that more than 1,200 delegates have registered so far, and I extend a warm welcome to all of them. In this year's meeting, we have introduced an INASL symposium covering some burning issues in the hepatology, and I extend a very warm welcome to INASL team. The aim of this meeting is to explore various important aspects of the liver diseases, that is pathogenesis, diagnosis, and the treatment, with the goal being to better understand, diagnose, prevent, and treat these diseases. But academics are not only the function of these INASL meetings. There are also a place to build friendship and have fun. The scientific program this year is focused on hepatitis B and C, non-alcoholic fatty liver disease, alcoholic liver disease, acute and acute and chronic liver failure, vascular disorder of the liver, liver cancer, translational hepatology, etc. In addition, we have paid special attention on the pediatric hepatology and the surgical hepatology, including the liver transplantation. An additional feature this year has been a postgraduate course which is spent over the entire day, you must have seen since morning, and focused on complications of the cirrhosis and the viral hepatitis. Several members who have attended it have conveyed to me that it was outstanding. It is a matter of pride that we received a record number of the abstracts for the conference this year. The accepted abstracts have been published in a supplement issue of the Journal of the Clinical and the Experimental Hepatology, that is the official journal of the INASL. At the end, ladies and gentlemen, I assume all the attendees, whether trainees, clinicians, or basic scientists, that they would find the latest information in their areas of their interest at this meeting. Thank you very much.
Of the dais and dear friends, please accept the greetings from the INASL. First of all, I would like to welcome our chief guest, Dr. Hank. I would like to also extend the warm welcome to Dr. Asif Shareen, who is the director of the ILBS and a renowned hepatologist. I welcome Dr. S.K. Acharya, who is the dean and head of department of gastroenterology, AIIMS, and a very renowned gastroenterologist. And I welcome all the faculty who have come from different parts of the country, the faculty from overseas, and the Indian faculty, and all the delegates who have come in large number to attend this scientific meeting. As INASL actually, which was started long back with a very few members of less than 100 members, and now it has gone up to the strength has gone up to almost 1,000. So, and not only that, this INASL is very actively not only conducting the different meetings, scientific, and impart the training and the interacting and keeping abreast with the recent trends and knowledge in the field of hepatology, where the people come from different parts of the country and they interact with each other and they get benefit out of that. Besides that, we are also doing the different health camps, health educational program, monothematic meeting which is conducted in different parts of the country. Basically, idea is to impart the training, and we want to keep our medical personnel well updated in the field of hepatology. Now, beside this, the INASL has got many more activities on the field of research also. We have many task force, particularly like on hepatitis B, hepatitis C, DILI, alcoholic liver disease and ECLF, which have completed. And not only that, based on that, we have collecting the data and we are publishing the practice guidelines from time to time in our esteemed journal. We have a very official journal, that is JCH, Journal of Clinical and Experimental Hepatology, which is a very good quality journal with a good impact factor, and which is time to time they are publishing very useful article, not only contributed by the foreign hepatologists, but our Indian also, they are contributing to this journal. Now, beside this, we have the registry also we have started for like hepatitis B and C. This is center registry where people can register directly, so that we are collecting the data, and based on this data, we are probably in the next few years will be able to publish because these guidelines keep on changing. So friends, this annual I welcome you all to this 24th annual scientific meeting of INASL, which has been, as Dr. Dhiman said, already we have registered almost 1200, and this is a very successful meeting, and I should congratulate actually the organizing team of the Dr. R.K. Dhiman and his team for this day and night hard work. Because of that, this meeting could have been successful. I once again welcome you all, and this is a very good venue, and the program has been made in such a way that it covers almost all the important aspects of in the field of hepatology. And not only that, we have started this time, as Dr. Dhiman has said, the joint program of INASL and the INASL. I think this was quite useful, the post-lunch session we had, and everybody enjoyed it. So once again, I welcome you all, and I hope the next 2 days also you will enjoy this academic feast. Thank you very much.
Thank you, sir, Dr. V.K. Dikshit. May I now request our chief guest, Dr. Hank Beckedham, WHO representative to India, New Delhi, to kindly inaugurate the function with the lighting of the lamp. May I also request the other dignitaries on the dais to kindly join our chief guest in doing the same. On that auspicious note, with the flames of that beautiful lamp glowing bright, may I now request our chief guest to kindly come up to the podium and present us with the inaugural address.
Dr. Shiv Sarin, the director of the ILBS, and a great inspirator about putting hepatitis on the agenda here in India, and that's not a small task. But also all the other people on the dais, like Dr. Subrata Chara from the AIMS, Dr. John Dilawari, Dr. Vinod Dixit as the president of the society, and Dr. R.K. Dhiman, the secretary of the society, and Dr. Sunil Taneja of the organizing secretary. You are all inspirational for the fight of hepatitis in this country and beyond. Invited experts, delegates, ladies and gentlemen, and if there is still somebody from the media, also the friends of the media, good evening. It's indeed an honor to be present here with you, the specialists, the people who know about hepatitis, who know hepatitis in and out, and who live for it, To be over here, I think it is indeed an honor. And to be this time over here on the occasion of the inaugural function of the 24th Annual Scientific Meeting of the Indian National Association for the Study of the Liver is indeed an honor. I'm sure that it did not go unnoticed that we just concluded the global event on the occasion of the World Hepatitis Day in Mumbai on the 28th of July. Amitabh Bachchan became the star performer. He was sharing how it is to be a hepatitis patient. He expressed the need for greater awareness and investment in fighting hepatitis, both for treatment and prevention. His words carry far. I think some of us was with him. I can tell you, when he entered the room, it was all about him. And then get somebody like himself to join the fight in hepatitis, it is great. And he's very committed. He even is committed not only for India, he's also committed to do it beyond India. And we are very honored and very pleased that we have somebody so effectively and enthusiastically joining that fight. We need him, as it is not an easy fight. You as expert and specialist, you know this. But we need you too, to start an effective fight against hepatitis in India. Hepatitis is a complex picture which requires expertise both in prevention, treatment and in care. You know, sometimes when we talk about diseases, it's relatively straightforward. When you talk about hepatitis, it's quite complex. Of course, hepatitis A, B, C, D and E have all something in common, but they're different too. And therefore, I think we need people like yourself to join the fight. We are glad that WHO at global level has now started more effectively the fight by adopting the first global health sector strategy on viral hepatitis 2016-21. This was adopted during the recent World Health Assembly last May. The strategy itself is basically about preventing unnecessarily illnesses and deaths and introduces the first ever global targets for viral hepatitis. And these targets are part of what we call the Sustainable Development Goals. Now, you might not think that is so important. As clinicians, sometimes you might think like this. But I can tell you one thing about indicators in global frameworks, where on an annual basis you come together, they become very powerful because countries need to start reporting on it. And that's the power. So that is one reason why I think on the global agenda it's there. These two indicators which I would like to share is as follows. A 30% reduction in new cases of hepatitis B and C by 2020. That is around the corner. And a 10% reduction in mortality by 2020 also. Why a strategy and targets now? Actually, the global attention for hepatitis is long overdue. As WHO, we are an organization of science. But what happened? If you look at the numbers, it should have been on the agenda a long time ago. Viral hepatitis is a major public health problem globally that affects nearly 400 million people, more than 10 times the number of people living with HIV/AIDS. Globally, viral hepatitis has become one of the leading causes of death, killing 1.5 million people annually, which is similar to TB and HIV/AIDS. Myself, I worked for 7-8 years, I worked in Africa. And there for sure, HIV/AIDS, TB and malaria, it's great to have it on the global agenda. I lived and worked now for 18 years in Asia. And in Asia, hepatitis is a far much more bigger problem than some of the other diseases. It's good that we have the attention for the other diseases, but it has been overdue for hepatitis. But we're glad we're getting there now. India has also a high burden of the viral hepatitis. But we have here a bit of a problem. How big is the problem? How much do we know? You have been talking today about treatment of hepatitis C. Myself, as you most likely heard, I was the WHO representative in Egypt. And they were globally, as a low middle income country, were the first one who were able to start treating en masse. They have treated 400,000 patients. But one thing what Egypt has, and which I still think is a challenge in India, they had a very good surveillance system. If you don't have a good surveillance system, even when you have new tools, then it might be very difficult for patients to benefit from it. This will be one of the challenges what needs to be put into the National Action Plan for hepatitis. But in India, we have an estimate about 40 million people with chronic hepatitis B and at least 6 million. I think I've spoken to some of you and you say it should be actually 12 million. But actually we don't know. And this is one part which I think we see as one of the challenges. The chronic hepatitis, if you look at the deaths, it is 176,000 people die here in India every year. That is twice as much as HIV/AIDS and malaria altogether. So for India, that hepatitis comes at the fore. It is overdue, but it is very good that it is now. There are two other major reasons why there is now more attention for hepatitis. In the prevention, there are some new initiatives and there is more clarity. In the treatment, you have already been discussing it. There are new developments, especially the new drugs that can cure hepatitis C is an enormous development. Please allow me first to touch upon the prevention part, and I will touch upon 4 areas. Awareness and prevention overall remains the mainstay of our response. Immunization, that's the first one. The majority of persons with chronic hepatitis B virus are infected at birth or in early childhood. Immunization is the most effective strategy for prevention of hepatitis B virus infection. I was also the WHO representative in China, and China had very high rate of hepatitis B. But with a very effective program, starting in the 90s, but actually more effective during the 2000s, these numbers has gone drastically down. So also here in India, there's good progress on the vaccination on the hepatitis B third dose. That's around 85%. But what is not yet done well enough is the bird dose. The bird dose coverage is lower than 50%. And that is no need for. At this very moment, the number of deliveries in institutions is 80%. And in that sense, I think we have some catch-up to do. Facilities who are facilitating birds should also make sure that their children are immunized from day one. And this is something imperative, that we give our children a healthy start. This is something what needs to be done and needs to be scaled up. Also, I wonder how much, but I think you most likely know, I don't even know if all the healthcare workers in India are vaccinated for hepatitis B. If not so, I think this is an area where we also need clearly to put it on the agenda. The second area of prevention is the safe medical injections. Most hepatitis C and hepatitis B virus infections are due to unsafe medical injections and other medical procedures and practices. This is in addition, of course, to the injecting drug use. In India, it is estimated that about 5 billion injections are administered every year. Actually, I still think it's an underestimation because that's around the 3 injections for a person per year. I came from a country, Egypt, where it was 8 per person. I think Egypt is somewhere between the 3 and the 8. So you have an enormous amount of injections. One thing is very important that we need to realize, if you look at the injections, about 15% of the injections in the country are done around immunization, but 85% of them are happening in the therapeutical part, in the people getting medicines. Now, for the immunization part, we have now the auto-disabled syringes, and India was one of the first countries who said, yes, we need to do that. So these injections are now safe. Now we have a challenge for the other 85% of a very large figure. At this very moment, we are very glad that the Ministry of Health has launched, together with WHO, a project what we call injection safety. And one of the first things what is there is starting the introducing of what we call a reuse prevention syringe. A syringe, when you once use it, you cannot reuse it. And that makes it instantly a lot more safer. We are very much looking forward to this. We know that already many of the companies are interested in starting producing this. If this will be introduced, and if there are sufficient syringes for India as a country, it needs to become mandatory to use these syringes. And I think that's the way the Ministry of Health is moving forward. I'm already very happy to know that in some of the states, at district hospital level, some of these syringes are already there. But we need to make sure that in India we don't think about a few districts, that is being done nationwide. We also think that India can once again show its leadership in adopting new technology and make all therapeutic injections safe in the country and beyond India to become a supplier in the region and the world. As many of you know, And I will get back to it. India is the pharmacy of the world. And it has also, is indeed, we hope as well for this part that they will be able to pick it up. The third area of prevention is safe blood. Here I will not dwell too much upon it, but we are very pleased that the government at this very moment is going through an exercise in looking at all their blood banks. In India, most likely, the major observation will be that you need to strengthen your quality control and that you need to set up a system which focuses on the service delivery, on blood services. In countries like Australia, which has only one center which is coordinating all the blood banks. In India, of course, you cannot think about one, but perhaps at every state, not more than one or two, we need to start thinking about this one, and we're looking forward for that assessment and a further discussion. Then, of course, the fourth one is access to sanitation facilities and safe drinking waters. This is very important for the hepatitis A and E agenda. Now, the Swachh Bharat, which is coming from the Prime Minister himself, or Clean India campaign, with its aim of an open defecation-free India by 2019, will be a major game changer. I would now like to move towards the treatment. Here I need to be careful. I'm talking to the specialists, but I'm sure you're very interested and keen in this area. But of course, with the recent availability of the newest, safer and relatively cheaper drugs of treating hepatitis C, we have now a great opportunity to provide treatment for those who are already infected. But what is very important, it is just like tuberculosis. If you treat people who are infected, you reduce the chances for people getting infected. And I think this is something what we need to keep in mind, especially when we are going to think about that we need to reach them all, because reaching all will cost money. But part of the picture is, and I think we are also using some of those models, if you start treating patients, then also the infection rates will really go down, etc. Now, here I would like to share a little bit of my experience, but again, you most likely have already moved there beyond. When I was in Egypt, I was very proud of them that they were the first country who started challenging the price of the drugs. Some of you know that the drugs in the US are $80,000 US for one course. They were able to get it down to 900. And while it was getting down to 900, they started treating. And proudly I dare to say that they have treated 400,000 people already in Egypt, with again very good success. But what it also has done, it started the price negotiations. At this very moment, and I'm looking at the dais as well, I think we're talking about a price of around $300. And we hope as well that it even will go down for the treatment. And here India plays a very important role. With involved in the generics, they are one reason why the price will still be challenged. And that's of course very important. $80,000, who can afford, for the low and middle income countries, to start thinking about treating their patients? Around the 200, it will be something which government should really start looking at, and I think it will be one of those good investments in public health. We are very pleased that some of the states are already moving forward, including also the Punjab government has embarked on a plan to make the Punjab state free of hepatitis C infections in the next coming 10 years. We hope that more states will be joining, including also Haryana and Manipur and JK. I think they're already also in this whole process. However, what is one thing is important, and I will be very honest, I will share my experience in Egypt. Initially, when the treatment started, it was well controlled. They set up 26 centers all over the country in Egypt. This is something what needs to be done here also in India. We need to make sure that the hepatitis C treatment needs to be done and guided by specialists like yourself. But it's also very important, and that's the other part what we are learning now from Egypt. Initially it was very well controlled by the National Viral Hepatitis Committee, etc. Now it is not anymore. Now people buy their own drugs, and people start treating, and even people who are not part of that, the specialists, they start also treating patients. Actually, we really hope that in India, and with support of people like yourself, here Dr. Saran has also been one of the people who we are looking at, but also other people here, that we really hope that we come up with a very strong programmatic part. You start your treatment while you have a laboratory in your hands where the virus is positive, and you end up with a diagnosis after 4 weeks and see if the patient indeed is cured of the virus. What we have also learned, and I'm not sure it has already been shared in Egypt they started doing it immediately after treatment, 4 weeks after treatment, and 12 weeks after treatment. But we already learned that after 4 weeks, it is as good as after 12 weeks. And in Egypt, what we also have learned is that most of the patients did not come back after 12 weeks. Well, it was far much more easy to capture them around the 4 weeks. This is something that needs to become part of that protocol too. So here we are. We have now a treatment, but we don't have yet a surveillance system which is strong enough. Now, this is one of the areas what we hope will go into what we call the National Action Plan for hepatitis. We are very glad that after the World Hepatitis Day, there was an occasion in Dr. Sarin's institute, and the Secretary of Health agreed in public, and I think the media has also been able to capture it, that he has agreed to start developing a national action plan. Now, what needs all to be there? It needs to be surveillance needs to be there. Infection control together with injection safety needs to be there. Hepatitis B vaccination needs to be there. Blood safety, awareness, the communication. And the treatment, of course, needs to be there and the research. I'm also looking at you for the treatment part to come up with a very good plan in this area. But on this one again, we need to make sure that we have a surveillance system, because then you might have a place to start treating patients, but if the patients, they don't know, as you know, and if you don't know where they are, then they will not come forward. Even in Egypt, while every single family in Egypt is affected by hepatitis C, at my age level, 25% are positive with hepatitis C. Even there, although there's enormous awareness, people don't know because you don't have the disease. You don't have any symptoms. So it will be a major challenge, but it will be very important. So I'm very happy to be over here. I'm very happy to be here with those ones who will be able to make the hepatitis fight in India a success. Thank you so very much.
Thank you, sir, for those very, very encouraging words. We will now proceed with the release of the abstract book. For this, I'd like to invite Dr. S.K. Sareen, Director and Head of Department of Hepatology, ILBS, to please release the book. Thank you, Dr. Sareen. Sir, could we please request you to kindly come up and say a few words?
Dr. Beckedem, my dear colleagues, the senior faculty from overseas, we are part of INASL. So having called us by Dr. Dhiman as guest of honor is probably his extreme love and affection, but we are part of all of you. Thank you, Dr. Dhiman, for having given us this extra honor. Dr. Dikshit had mentioned how INASL grew. I was reminded in 1988 when Dr. Nayak asked me, there were about 33 members in INASL. Gradually it grew up, and Dr. Ramesh Rupray from Jaipur held the first meeting of INASL. I think it was 91 or 92, in which Harold Kahn had come for the first meeting, and then now INASL is on a very high pedestal thanks to the leaderships in the past, Dr. S.P. Singh, Professor Acharya, many of you. I must also say that you were able to attract the best brains. That includes Professor Patrick Kamath and Professor Sanyal as part of India, but also Pavlo and many other colleagues. Also, the journal is doing extremely well, so we feel very proud. Back to what Dr. Beckedham said, I think each one of us want that the hepatitis elimination goals are achieved. But we have a very small capacity as an individual because we have a small contact area or maybe influence on people. But as a society, and as you have come to grace this occasion and have shared thoughts, I think the movement will catch on. 2020 is a very common thing in India for cricket, but it is also common that we achieve some targets. India has the capacity, once it gets into action and the people get into action, they really make a difference. They are the best people as far as cricket is concerned. They are close to best in hockey. They will probably be very good in also the field of hepatology. I have a few more thoughts. One, I think the leadership in INASL is in very good hands with Dr. Dikshit and in future Dr. Anil Arora having come and Dr. Dhiman as secretary. I think it's in very good hands. It's a time that we all put our acts together with no differences, no thoughts. Also, we have the Asian Pacific meeting in 2018, and I would request INASL in all its forms to join. Second is the initiatives, as Dr. Dikshit said, the programs like special interest groups or task forces, and Dr. Saraswat, who probably somewhere is joining, has taken lead in many areas. But I think we should all put our efforts together, and that will make INASL as a very strong body. The third thought is to get involved with the postgraduates and the younger faculty. There is no future in hepatology as of now. You know, like you do even a DM program, what do you do after that? You start practicing gastroenterology. So if you as a society, as an institution, unless you carve a new field where people like to join and have career prospects, hepatology as a specialty will probably not grow. I must say that let's say you go to Mayo or you go to Richmond, there will be areas like in NASH or HCC and others. So there will all be areas where people would be working in different types. So I think, and Professor Chawla will join us hopefully tomorrow, we all should work in a manner that hepatology as a career becomes. So we hope 200 transplant centers, probably by 2020, and about 200 hepatology, trained people are available by another 5 years. I think we have a lot to do, and I encourage you to join hands. And once again, Dr. Dhiman, for your leadership, for your humility, and the manner in which you organize this meeting superbly. Salutations to you and INASL. Thank you.
Thank you, sir. We now go on to releasing the INASL guidelines. For this, I would like to call upon Dr. Shubhrat K. Acharya, Professor and Head of Department of Gastroenterology and Human Nutrition, as well as Dean of All India Institute of Medical Sciences. Sir, we request you to kindly release the INASL guidelines. May I request Dr. Acharya to come up and just say a few words, sir, please. Thank you.
Good evening, friends. I think I was a part of INASL. I'm a member of INASL from such 30 years. Has been a young man, has been working for INASL as a legman. And it is very kind of Professor Dhiman and the INASL team to call us as a guest of honor. We are indeed a part of you. Therefore, we don't think that we should be the guest of honor. We are actually the part. Over 30 years period, as Professor Sareen has suggested, INASL has taken giant strides. Yet we have to achieve a lot. Before I say my thoughts, I must convey my gratitude to Professor Dhiman, Professor Vivek Saraswat, Professor S.P. Singh, and many others who during last 15 or 20 years has done immensely for this society, and we have in front of our eyes has shown how the society has grown, not only in membership, but having scientific meetings, its improvement in academic content and research in liver disease, as well as developing the journal, developing guidelines, developing various task force, which actually clarifying not only our minds, we are collating huge amount of data. Since the WHO representative is here in this gathering, I would like to tell you, think about four distinct areas. You see, India is a funny country. We have about a huge population, and we have till now not been able to provide safe water, which gives you hepatitis E and A. We've just started hepatitis B virus vaccination, and 14 states has, health is a state subject. 14 states has started it, and we need in hepatitis B, unlike other immunization, 80% coverage to have an impact on the disease burden and decrease in carrier rate, which has been already shown. We have to achieve it. We started hepatitis C screening in 2002 and realized that we are using unsafe syringe and injection practices widely prevalent. The effort has just been started. We have not controlled hepatitis E, B, or C, but alcohol sales has increased tremendously. And I believe, if you see the reports on acute and chronic liver failure, from superinfection of hepatitis C, alcoholic HELF has become more dominant now. We are independent since 66 years, and for 5,000 years, we had undernutrition, as a result of which there was a genetic switch which has not been studied, and therefore Indians are more prone because you don't have storage place, you don't have adipocytes in your body, subcutaneous adipocytes, and therefore you have started developing fatty liver disease, metabolic syndrome, diabetes, coronary artery disease, and hypertension, and non-communicable disease has increased. If you ban alcohol, give safe water, do hepatitis B virus vaccination, use safe injection practice, right, and increase awareness, and ask the people to exercise, 95% of liver disease will vanish. The hepatology is a discipline, and liver transplant may not be necessary. I think that's the realization, and this is the contrasting thing. Third thing I want to say, despite knowing all these things, we have not put on any efforts till now on these areas. And now we are showing data that in contrast to HIV, tuberculosis, malaria, the mortality due to hepatitis is significantly higher and is increasing. And to contrast to it, I just asked a few days back, Professor Jujam was here from Germany, and I simply asked him how many experts you have. You have 60 million people to take care of liver disease. He told he's 5,000 experts. we have 1.2 billion, 1100 million people, and we have 1500 or so trained gastroenterologists. Therefore, not only thinking or planning and discussing about this is important, a realization of these facts are important, and most important thing I believe is increasing human resources. That's what Professor Sareen has just mentioned, that multiple places DM hepatology has started, but what they will do is the question. Huge amount of work, sir, in this country. You have taken the leadership, and you have to push it and increase this human resource, which is very rare, large. If you have a large human resource, it will have an impact on population. And lastly, as gastroenterologists, hepatology, we are very possessive about the disease. Despite knowing that, the information, education, counseling, vaccinations, and easy therapy should go out of the domain of hepatologists to physicians, which are the first contact point of most of the patients who have disease, who comes to them. And in there is a gap. The gap is twofold. One thing, the knowledge is liver disease liver has huge reserve, and therefore liver disease is silent, which neither the physician nor the patient realizes, because over 20 years they feel fine. That's the gap. INASL as a society has, from infancy, has become an adolescent. Now it has become an adult, and increase its domain and outreach, and invite physicians and general practitioners to its fold, forming advocacy group to control hepatitis in this country. It's very nice and very heartening to give a call that control hepatitis, but eliminate hepatitis by 2030. That is World Health Organization decision or declaration this year, no HEP. But to successfully conduct that in this country, we indeed need human resources which should be considerable, with knowledge, with enthusiasm, and commitment to control this. I'm not a part of executive, but I'm sure Professor Dhiman will agree. All of us in this house, the whole Indian National Association of Study of Liver is prepared to join hands with the World Health Organization to do and achieve this commitment in this country. Thank you very much.
Thank you, Dr. Acharya. And now, ladies and gentlemen, we come to the most prestigious part of this inaugural ceremony. Yes, the conferring of the Lifetime Achievement Award in the field of hepatology. The recipient of the award this year is Dr. J.B. Dilavari. Dr. J.B. Dilavari was fortunate enough to have his undergraduate medical training in one of the best medical schools of German universities in Munich. His postgraduate training in medicine and gastroenterology was in the London University hospitals like Hammersmith, Central Middlesex, and Royal Free Hospital. His training in gastroenterology was with Sir Francis Avery Jones, father of British gastroenterology, J.J. Misiewicz, President of the British Society of Gastroenterology and editor of Gut, Margaret Shiner, inventor of the Shiner capsule, P.B. Cotton from ERCP, and Christopher Williams, colonoscopy. His training in hepatology was with Laurie Blendis, Dame Sheila Sherlock, and Roger Williams. He has more than 200 publications in several prestigious journals. His significant contributions in the field of gastroenterology include study on absorption of complex carbohydrates, which form the basis of the glycemic index of food items, the study of portobiliopathy in patients with portal hypertension, the development of spontaneous shunts in portal hypertension, published by Gastroenterology. He has received many Lifetime Achievement Awards in the past, the International Association of Pancreatology and the Pancreas Club India, as well as the Lifetime Merit Award from NHS UK. In his career, Dr. Dilavari has held some highly distinguished positions: Commissioner, Commonwealth Commission UK, President of Indian Association of Study of Liver, which is INASL, and advisor to the Indian Council of Medical Research. He was the first to introduce ERCP in the Indian subcontinent 35 years ago, making this a landmark pioneering contribution. He has trained numerous postgraduates in gastroenterology and hepatology while working in the PGI Chandigarh, which includes some stalwarts and doyens in the fields of endoscopy, hepatology, pancreas, and pancreatitis. He worked closely with distinguished colleagues while at PGI who have received worldwide recognition in the field of hepatology, like Dr. Y.K. Chawla, Dr. R.K. Dhiman, and Dr. Ajay Desuja. May I now request our Honorable Chief Guest, Dr. Hank Beckerdam, to kindly confer the award to Dr. J.B. Dilavari. May I request Dr. Dilavari to please come up to the stage to receive the award. Absolutely. Dr. Dilavari, it would be an honor for us, sir, to have you kindly come up and give us a few words. Congratulations.
What can I say? I'm really overwhelmed. I can't believe it that I've been honored with this prestigious award. But let me tell you, this award is not for me. It is for those people who have helped me to get to this stage. And those were my inspirational teachers in Germany, in UK, and also those were my students in Postgraduate Institute Chandigarh and my colleagues. And some of them are sitting here, and I'm so grateful to them. They have helped me and contributed a lot of work which have brought me to this stage. So on behalf of my teachers, behalf of my students, and behalf of my colleagues, I accept this award, and I say thank you to INASL for giving me this opportunity to have this award. Thank you.
May I now request our dynamic organizing secretary, Dr. Sunil Taneja, to kindly present us with the vote of thanks.
Good evening. Dr. Hank Beckerdam, our distinguished chief guest for the occasion, Professor S.K. Sareen and Professor S.K. Acharya, our distinguished guests of honor, our esteemed faculty, distinguished delegates and invited friends, ladies and gentlemen, I stand before you with a deep sense of honor, privilege, and humility to propose the vote of thanks for the 24th Annual Scientific Meeting of INASL. At the outset, I would like to express our profound gratitude to Dr. Hank Beckerdam, WHO representative to India, for having taken time of his many responsibilities to join us here today, to share this occasion with us, and indeed for having inaugurated our conference. Thank you very much, sir. I would like to express a sense of obligation to Professor S.K. Sareen, Director ILBS, New Delhi, for taking out time from his busy schedule and for his kind guidance for the event. We are also extremely grateful to Professor S.K. Acharya, Dean AIMS, New Delhi, for his constant and meticulous guidance in making this conference happen in India, in Delhi, and also in inspiring us to host it successfully. We convey our sincere thanks to Professor V.K. Dikshit, President INASL, for gracing this occasion. For the first time in INASL history, ISL has endorsed our annual scientific meeting. I thank ISL for extending their support and participation. I take this opportunity to extend our gratitude to the distinguished panel of speakers from India as well as overseas, our national faculty, delegates both national and international, and postgraduate students for having traveled from near and far off to participate and contribute to this event. I would be failing in my duty if I do not convey my thanks to the pharmaceutical companies for providing us monetary support to organize this conference. I thank all our prime sponsors, including Cipla, Zydus Healthcare, Dr. Reddy's Lab, Natco Pharmaceuticals, and Myelin Pharmaceuticals for this support. I also thank all the other pharmaceuticals, including Torrent Pharmaceuticals, Sun Pharma, Abbott, Hetero, Emcure, Win Medicare, Alembic, Olivine, Biocon, SRL, and Olympus for this support. Lastly, I thank all the members of the organizing committee, Shifari Singh and her team from Maisha, our travel and hospitality partners, Mr. Sukumar and his audiovisual team, Saurabh Mehrotra and his team from Hyatt Regency, and all my colleagues who have been involved in this particular exercise for the last several months, who have worked tirelessly in organizing this conference. Without their cooperation and full support, this conference would not have been possible. Thank you once again. We look forward to an extremely productive 2-day session. Thank you so much.
Thank you, Dr. Taneja. May we now request you, ladies and gentlemen, to kindly stand for our national anthem.